We're going to get started the next session. The next session is a lower extremity arterial thrombectomy. We have our esteemed panels, and we're going to have a few more joining us. Dr. Varkis on my left, Dr. Hammad is on my right, Dr. Tsai is on my right as well. And am I missing one more person? And Dr. Ramanan? Oh, she's over there. All right, so is Dr. Yoon, okay, perfect. Can we have the mic from Dr. Yoon, please? Okay, perfect. So Dr. Yoon is going to be talking about a pump-assisted thrombectomy, and we'll try to make it more interactive.
Okay, thank you very much for the invitation, and I'd like to present a case where we use a pump-assisted thrombectomy. Okay, so this particular patient is a 60-year-old male patient with acute limb ischemia 2B with sensory motor loss with usual past medical history including heavy tobacco use, hypertension, hyperlipidemia. The patient had right ilio-SFA obturator bypass in 2021 and then later also had a more distal bypass from the right POP to AT with reverse GSV. The patient present with this CT scan, as you can see here. You'll notice occlusion coming soon on the right side, and the bypass has tunneled in the obturator canal and then coming into the SFA for distal anosmosis. Fortunately, this patient had a patent right POP to AT bypass that stayed open despite this going down. The issue was this patient presented with the symptoms for more than 24 hours and also had a delayed transfer process. So the issue is obviously the patient has stage 2, 2B acute limb ischemia, which requires urgent revascularizations. And the challenging part is that patient had multiple surgical histories, one being obturator bypass, which is a bit more difficult to access, and of course, which require urgent revascularization. So there are many different ways to do this, obviously, and the one is usual forward thrombectomy. But given that this is a very long bypass going to obturator canal, and sometimes a forwarded catheter is difficult to pass. So in this case, we decided to use radiographic or fluoroscopic guidance and use a pump-directed thrombectomy catheter. And here's a case here. We obtained access in the distal bypass, which is shallow for us to access. That was in the retrograde fashion, the bypass crossed, and we're using this penumbra lightning catheter to go into the aorta in the ipsilateral side under guidance. And this was after the first pass, and you can see that there's a residual thrombus. And we had a second pass through this and had an actually really good outcome, which you'll see soon.
What size bed number is this one?
This is a flash.
Flash 16?
Yeah.
Okay. So you have a surgical access from...
Right. Yeah, because this requires 16 French, and also I had to pass it distally. So having 16 access and going back and forth is quite difficult. So this was open cut down in the shallow area, and then we were able to go retrograde and integrate and remove most of the thrombus. And we'll have, this is one of the material that we got because it's sort of a subacute phase. Although the patient has a severe motor sensory loss, so you can see there is quite a bit of organized thrombus that came out through this lightning flash. As we all know, this catheter has been, this type of mechanical aspiration thrombectomy has been used quite extensively. And the right case and the right anatomy, I think this has a very high success rate, and of course, through that, very good outcome. So I think key learning for this is picking the right case for this catheter and choosing the right timing for this. Sometimes patients need thrombolysis, but of course the benefit of this is avoiding using any thrombolysis and patient going to ICU, and sometimes you run into bleeding issues or sheath not working, catheter being clogged, or having a kink, and of course thrombolysis itself is not very cheap. So we cut down the ICU stay, and not having to use thrombolysis, of course, is a benefit. I think it mostly makes a more, we make a lot of costs through that, avoiding these high-level intensive care stay. To that, I would like to open up to any discussions or questions. Yeah, thank you.
I think this is the fastest talk for the day. So we're gonna have a lot of questions for you and for the panel. So can you just go actually, you went through it very quickly. You made it sound super easy, but this is not easy, right? So the question, this is in this situation, you have this graft is all the way down. And so talk to us about the access. Why did you decide this kind of type of access, and what other alternative you have?
Yeah, so patient is obturative bypass. So getting into abdomen is of course not easy because of redo abdomen. And because bypass is tunnel through the pelvis, of course getting access in that point is also very challenging. So the access to that point we selected is where it's shallow. So distal anesmosis area where it's quite shallow for us to access. Just because we knew this particular graft was 8 millimeter in size, and given that we're doing open access to begin with, obviously then naturally you want to use bigger catheter as possible to get the most of the thrombus out. And because also this is surgical bypass conduit, we can be quite aggressive about it. So after opening the distal thigh for an access, and then you can really be aggressive with the catheter. And you want to be quick because this is quite a large catheter. You can have a significant amount of blood loss, which can make anesthesia quite nervous.
So we have two surgeons on the panel. So when do you decide, I mean, this is a very unique case, but when would you decide surgical with Fogarty balloon versus mechanical thrombectomy?
Yeah, I think I would have done the same, the penumbra, mostly because it's actually hard to pull all the stuff out with a Fogarty. The operator bypass is pretty rare, and they have pretty poor patency, so I'm not surprised it went down. I feel like you just wait for the next time it's going to go down. But I think if it's not really acute, it's very hard to get it out with just a Fogarty. And then it helps to have the suction with the penumbra. Now, I did wonder how you addressed distally. Did you just clamp it and then turn it around?
Right, that's the benefit of having open access, that once we were established inflow, we just clamp the graft, and then we just redirect the sheath distally. And
then do you do the flash going down, the SFA2, or did you, in that case, I would have used the 7 French, or you could put a Fogarty down that way, although that again, you never know if you're going to drag out some plaque with
right, for the distal part, we actually use a Fogarty catheter because on the CT scan, the occlusion was quite short, and the distal bypass is open. Had the distal bypass been down, I think I would have used a smaller penumbra catheter for that, because the CT showed that distal bypass is open. It just made natural sense to just do a quick Fogarty thrombectomy for the distal end of it.
And then how do you, or anyone with these sort of, operator bypasses, how do you manage them post-operatively? I've always anticoagulated them. Full anticoagulation, low dose Xarelto. Any thoughts about that? Because this is going to go down again. That's just the nature of the operator bypass.
Yeah, exactly. When people are doing operator bypass, of course, it's one of the last resort sort of a revascularization technique. For this patient, we went with the full anticoagulation with antiplatelet therapy. The old Dutch data with the Bala trial where, the PTFEs is better treated with dual antiplates and the GSV being vitamin K antagonist. But we don't normally always follow that. And when, especially a patient who fails interventions like this, then we try to go full force with the anticoagulation.
So Dr. Ramanan, so you just heard your vascular colleague saying this is bad bypass, it's going to fail. So what are you going to do with these patients? Are we going to wait for the next time failing, or what would you do next for this patient? How do you survey them? What do you offer them if this is, you expect it to fail?
Well, I think surveillance is important, but unfortunately when these go down, they present with pretty acute limb ischemia, just like he presented, pretty advanced Rutherford limb ischemia. We do survey bypasses with ultrasounds pretty routinely, so usually in the first couple of years we do pretty frequent ultrasounds, every 3 months for the first year, and then 6 months in the second year, and then yearly after that. But again, there's really no way to predict unless the patient had some kind of stenosis, which we see on ultrasound. Sometimes there's no way to predict why the bypass failed or when they will fail. So in your patient, did you find an anatomic reason for why the bypass failed?
No, we didn't find anatomic reason. I think the patient has basically single tibial vessel runoff. So that's really the big problem, and that runoff is based on the bypass from the POP to AT. I think it's just the fact that patient's also using tobacco clearly doesn't help. Anatomically, there was no significant stenosis that could have predicted it because patient was actually going under surveillance program by my partner, and it just happens that this patient had acute limb during that surveillance period.
I agree with full anticoagulation like you did for this case.
Perfect. So let me ask Dr. Hammad and Dr. Varghese, let's say you're in a hospital that you don't have the privilege of having a vascular surgeon who can make a cut down in this case. Is there a way to treat this patient percutaneously? Contralateral, pedal, is there a way?
I think you can go radial. I think contralateral is going to be tough because you don't have enough pressures to place a sheath because the other clot went all the way almost to the awesome of the common iliac. I think radial would be an option, but I think best would be like he did retrograde because going radial also runs the risk when you suck the clot and you come back with a catheter, it can escape and go to the other leg.
Yeah.
I think retrograde would be the best option.
So
Exactly.
for the radial, I think from a 6 French perspective, the only radial catheter will be the imperative care 6 French, but it's not going to have enough suction for it, unless you want to do maybe a 7 or 8 French brachial, maybe.
I think the other thing also would be also the shaft length. I don't think we have enough shaft, length to go all the way from radial down beyond extended iliac. I mean, you can do subclavian axillaries. That would be a bit, extreme, but it's an option. But I think retrograde is the best way to go.
So I'm in a hospital. I don't have a lot of privileges to have vascular surgeons come and do cut down. First of all, was this case cut down case?
This is cut down case, yeah.
Okay. So what we do usually is go with one of the other thrombectomy device, 7 French. We have the Penumbra or Jedi thrombectomy. So one of the things I have found, even the literature, a good proportion of the cases you have to use adjunctive thrombolytic therapy because the subacute thrombus is not going to come out completely with thrombectomy alone. So I would have gone with a 6 or 7 French radial or even popliteal. We could go endovascularly, but if there is still residual thrombus, I would put a ECOS catheter for 8 to 10 hours to decrease the incidence of bleeding complication. So that's what I would do, and I think it's very important to discuss the post-treatment thrombotic therapy because in my personal opinion, these patients need to be on a antiplatelet and an anticoagulant.
Yeah. I mean, go ahead.
Concerned of your mechanical thrombectomy that if there was some residual clot left in the graft, it would embolize downstream because that thrombus is not impregnated with coagulation.
Right.
Non-vessel runoff could cause acute limb ischemia in 10 hours.
That's a very good point. And when we did a cut down, we had a distal clamp on. So we knew distal embolization wouldn't be possible because we had. Okay, yeah. So. Right. So what we did is, when we did distal thrombectomy, we did the catheter injections to make sure there was no residual thrombus that could embolize. And once that was done, then we reestablished the flow. So we had confirmed that distal outflow was okay before we reestablished the flow, the native flow, if you will.
Good point. Yeah, I think someone asked the question. You need to know why this happened. If you don't know, this is going to happen again. So I think a poor outflow is maybe the cause of this patient failure. Well, thank you so much. It was very informative. It was a great case. I think next is Dr. Hammad is giving us a talk about hydrodynamic thrombectomy.
Okay, thank you. So No disclosures. This is a 76-year-old lady who actually went for an elective SFA intervention for left lower extremity CLI. She had a non-healing wound in her medial malleolus at outside facility, an hour away from us. And the intervention somehow was complicated by left popliteal thrombosis and subsequently acute limb ischemia stage 2A, some numbness but no motor deficit. They have attempted to do thrombectomy but failed, so what they have done, they place a local TPA infusion catheter and they send her to us. Pertinent history, heart failure, remote standing coronary pacemaker, and she's a COPD inhibitor of home O2. So what we did, she arrived to us around, probably close to 5 p.m. So we continued this was an afternoon intervention, and so we continued the TP infusion till next morning, and then we took her back to the cath lab, for the first time for a Lysis check at our facility. And here's the pictures. Of course, they have not addressed the SFA lesion because this was a complicated procedure. So you still see the SFA lesion there, is tight, mid to distal. In the left side panel, mid panel, you can appreciate the popliteal. Distally is basically occluded and full of clot. And then on the right side panel, you can see below the knee that you have a clot that extend into the TPT peroneal proximal portion, and also I don't see you see some of the AT proximal, but then it occludes distally. So attempted thrombectomy at outside facility already without success. Still no distal pulses, stage 2A acute limb despite 18 hours of local TP infusion, and you have the above angiogram. So what would be the next step? Of course, the thought process that we're going to attempt thrombectomy again, we can leave it alone, and we're going to combine this with balloon angioplasty. But the thought process was to attempt different device of thrombectomy. And I have no relationship with Abbott, but I like their device, the new device Jeti, and the reason for that, because I truly feel it does combine, two actions, not just the aspiration mechanism, but also, fragmentation of the clot using this high pressure saline jet inside the catheter. I feel like sometimes it does a job. So here, you see my command wire all the way down to the PT. And here in the left side panel, in the second one from the left, you see the Jeti catheter. And the video didn't play, let me see. Thank you. Okay, here you have some flow. Now we can see some flow from the popliteal into the AT, but I think there's still thrombus in the TPT. So we balloon that TPT, PT, and on the right side panel, you can see the flow is better, but you have significant residual clot in the TPT, and I think it's causing critical narrowing. I think close to 90%. I was debating actually, should I leave it alone? Should I touch it? But I just felt the outflow is not good, and they have to take care of the SFA lesion. So I was worried everything gonna close up again. So so we decide to attempt more thrombectomy, only in the TPT, not into the PT, because as you know, the device doesn't go in small vessels. So you can see in the left side panel, the tip of my aspiration catheter right below the prosthesis. Can we play the panels, please, the videos? Second, thank you.
Was that a 6 French or 8 French?
6 of French. 6 of French only.
So while playing, let me ask the panel. I don't want to try to be better. I think it's an important question. So what is good enough? Like when do you think we're done with? I mean, sometimes you keep chasing it, and then so from the panels, Zach, can you comment about if you have an acute leg, you have clot like this, what's your goal? What are you trying to achieve? When do you say, I'm good, let me stop?
I think if you can reestablish inline flow to the foot and you have a pulse again, if that's what was, I mean, this person didn't have a pulse to start with if they had a popliteal occlusion, very likely. But if you have a pulse again and you have Dopplerable signals in the foot, I think I'd be at that point in time, knowing that you do have flow past that thrombus, you push more equipment down there, you're just going to continue to cheese it. And so depending if you want to keep opening up more pieces of equipment, I think what you've done here is reestablish flow. At that point in time, I would probably stop, knowing that you have flow around that thrombus. This is someone that we're going to be putting on anticoagulation. Maybe even you do Lovenox initially versus doing one of the NOACs right away. At the point that you have here, I don't think I would chase further down the AT for sure.
Agree. You need to get at least some flow to the foot. I mean,
I
just
agree.
having the SFA probably open, you really didn't achieve anything. So I think what you're doing is absolutely correct. I mean, you're trying to get some blood flow. Otherwise, all the work you've done is just not enough.
Great points, Zach. Thank you. Actually, I always, when I do these cases, I feel like less is more sometimes. So definitely, with acute limb, you just need to establish flow. But what we need to remember in these patients, that this patient had a significant SFA lesion that need to be addressed, likely with a stent. So I was worried about the outflow, and also she's an ALI on top of CLI. She's a lady with a malleolus wound, so you need to make sure you have a good flow to that territory. I'm sorry I don't have the foot angiogram prior to me attempting another thrombectomy into the TPT, but the flow down that PT was really sluggish and slow. So here again, thrombectomy just into the TPT. Can you play the second panel, please? No surprise, I think now the thrombus went, we got lucky. I mean, this is still not the one. Okay, so here the result, not impressive. We did balloon angioplasty now, and we addressed the SFA. We put a stent, we post-dilated, and I'll show you pictures in the next panel. Here we go, that's the SFA lesion now. And that's below the knee, and no, surprise, sometimes, as I said, less is more, but thankfully went to the peroneal, and the PT where the wound is stayed open. At this point of time, of course, I'm not going to chase this peroneal, I'm just going to accept the result and call it a day. I think we got good flow to take care of the acute limb and also take care of that one that she had. So next step, of course, no more stop. And this is her, left side ABI and toe pressure after the procedure, second day. She only saw me remotely because of, she's an hour away, but she followed with her local vascular podiatrist. But 6 months virtual follow-up, 90% healed her wound, and of course she had no more ALI symptoms. So I think the key message is to be familiar with the different thrombectomy devices. You don't need to know all of them because you have like maybe 5, 6, 7, there are 10 of them, but at least 2, 3 with different mechanisms of action, and know each one very well. Know when to stop, to Zach's point, and less is more sometime. And angiogram is irrelevant in acute limb, but it is relevant in a critical limb ischemia as to this case. Thank you so much.
So Dr. Tsai, let me ask you this question. I think it's important to understand this is not this is a true multidisciplinary approach kind of disease. So this patient had few days in the other hospital. They tried thrombectomy. They tried, TPA. It didn't work. And then you come in and you get all this work, and now you have a vessel open. How concerned are you for compartment syndrome or reperfusion injury or something like this with a delay of this patient therapy? So what would you do? How do you monitor this patient?
I think it depends on how ischemic they were beforehand. If they are chronically ischemic, the likelihood of a compartment syndrome is low, but not impossible because I had that happen to me. But if this person had palpable pulses before and was ischemic for this long, I would probably do a fasciotomy at the time of revascularization. But it does, it depends on how they present, how bad their ischemia was beforehand. But usually, if you're thinking that you need to do it, probably you should be doing it. In someone who is chronically, has chronic limb ischemia and they had intact motor function and we revascularize them, I think you still have to check. So we'll put them in the ICU and check CPK serially. And then even if the CPK is not increased, if they have clinical signs, like they have, decreased ability to plantar flex their foot, or numbness in the foot, or if their signals are a little different, you have to have a very low index of suspicion that there's a compartment syndrome going on, and then just do the fasciotomy.
Definitely, I think it's very important. Your job is not done by having a flow. This patient can get really sick really quickly, and for the surgeons, if our colleagues, we've learned it, I've learned the hard way. We had a patient that had an acute occlusion after an Impella, and basically what we found is actually aortic occlusion and femoral iliac occlusion, and we took him for surgery, and we ended up doing open, and the moment we have reperfusion, the patient just coded, and the potassium was 7.5. So I think it's important that managing thrombectomy is not just doing the procedure and getting the flow. So a patient like this, I agree with you. An ICU, at least for 24 hours, close monitoring, make sure the patient symptom is improving. For Dr. Verkes, so we always think about acute limb and we say, you go in, you take the clot out, it's great. So two-part question. Number one, what workup would you recommend? Because we don't know why this patient had an acute leg, right? So that's number one, what workup you do. And how often do we see an underlying peripheral arterial disease that you need to manage at the same time of a thrombectomy or the acute?
Good question. So before going into that question, I would like to point one thing. When I cross the acute limb ischemia thrombus, I would see how easy my wire goes into. Then I put a crossing catheter and take distal pictures. So I know whether it's acute or the patient has collaterals. So that is one way. I'm not saying that's a definitive way. That is one way of realizing whether it is acute or patient already has some CLTI. The second question is, what are the workups? So, interestingly, US, there is no standards for acute limb ischemia, even from Vascular Society. But European Vascular Society has some standards recommended, but most of them are expert opinions. So one thing I have found, I have enough structural volume came from my acute limb ischemia. You will be surprised how many PFOs, because cryptogenic stroke, there is an indication to look for TEs and, to look for PFOs. You'll be surprised how many patients have PFOs and no other disease. So there are multiple reasons for embolism. It could be atherosclerotic plaque. It could be a systemic embolism. So I will always do TE on every patient. I will try to identify other pathology. If I don't see any pathology, I will usually call my hematology oncologist to see the patient and evaluate.
Yeah, I think it's important because this, as we said, it's a multidisciplinary approach. If you're an interventional radiologist or a vascular surgeon, I think it's very important to include your cardiologist to do the workup. We had a recent case, very interesting, 30-year-old came with bilateral acute limb ischemia, and she had a huge myxoma, and she ended up getting open surgery. So it's important to figure out what we do. I think in everything we do, in an acute event, the question is, why did this patient have that acute event? And we should try to answer that question. Otherwise, this is a recipe for another readmission. We see it in the PE, we see it in a DVT, we see it in acute limb. Dr. Hammad, do you have a comment?
No, I agree 100% with the workup. I think in this case, though, it's probably more likely procedure related. But I think you still have to confirm was the ACT therapeutic, was it not? And if you cannot even though it was, I don't think you can just assume it's procedure related. You still have to do the workup. But if you have a very clear reason, ACT was, subtherapeutic, IV was not working, then maybe it's a clear, and you don't have to go with the workup. It's a clear cut that this was probably procedure related.
If you have an answer, definitely. So Dr. Ramanan, I asked Dr. Verkes, but he skipped that question, so I'm going to pass that question to you at this time. That's okay. So how often do you see in those acute limb an underlying peripheral arterial disease, and do you treat it the same time, or would you treat it on a separate occasion? I think you have a mic next to you on the right side. You have a mic on the other side. There we go.
So it depends on what's the cause of the acute limb ischemia. If the underlying peripheral artery disease is, say it's a plaque rupture, and that's causing the acute limb ischemia, then I think the underlying disease has to be treated. Otherwise, the patient's going to rethrombose and get another limb ischemia. So yes, if it is the limb ischemia is due to peripheral artery disease because of possibly a plaque rupture, then I would treat the underlying disease at the same time. I would say that we do see some embolic phenomena pretty often, but probably about 30 to 40% of people have underlying peripheral artery disease and present with acute limb ischemia.
Any other comment before we move to the next one?
So I will answer quickly that question. So acute limb ischemia, I would like to treat as acute limb ischemia. If there is collaterals, I will leave it alone. And there are situations, there is one case, patient had a closed SFA, patient became acute when the profunda was closed off. I just opened the profunda with a balloon and stent, patient did fine, kept the limb.
All right, so, yes, sir.
Dr. Hammad, do you think when you are advancing a mechanical thrombectomy device that you are pushing the thrombus downstream just by the...
It is very possible. That's why we try to go very slow, but sometimes it's just, some of these are unavoidable. But it's very possible. But that's why we emphasize that slow advancement, patience as you advance, millimeter every second or two even, and feedback depending on the device. Some of these devices they have feedback, washing the flow back, etc. But it is very possible, yes.
Great question. I think next presenter is Dr. Nanjundappa, and I think he had to travel, so I'm actually going to present his talk. So, one second. So it's funny that I was giving, me and him were giving a webinar the other day, and we had our name reversed. So this is second time in 1 week. So, all right. So Dr. Nanjundappa, he's from Cleveland Clinic Foundation. He actually had to travel for work. So I'm going to try to present his talk. So it's basically the conversation is the role of pharmacomechanical lysis in patient with acute limb or thrombotic vessel, and the question is. When do we perform it? The role of that, the lysis, what device? There's many devices in the market, and which device we should be using, and the technical part of it. So the acute limb ischemia can happen from an embolization. I think we just covered it. It can also happen from a local plaque rupture or just post-surgery, post-procedure when your anticoagulation is not sufficient. So the different devices, you can do the old-fashioned way, which is the Craig-McNamara, and just TPA for 12 to 18 hours. You can use the ecosonic fragmentation, or ECOS, that has a TPA drip with ecosonic fragmentation. And you can get the old pulse power spray if you guys old enough to use the Angiojet. Angiojet was the only option, and you can infuse the TPA and then just do the thrombectomy at the same time. A lot of the question that come up also is, can you use something else? Can you use, kangaroo lower or not just TPA alone? So there was a paper called the Style Study in 1996, and that was a very interesting and important paper to understand. In this paper, they studied the 237 patients, and they're looking at comparing patients with a thrombotic lesion. Can be femoral, iliac, or popliteal, and they're looking at catheter-directed thrombolysis versus surgical revascularization. And in this study, it shows it's favoring surgery. So that's the bottom line in terms of comparing the two, comparing the lysis versus the surgery. And if you look at it, basically the bottom line was that thrombolysis can initially provide a reduction of in the surgical procedure for the majority of the patient. However, long-term outcome is inferior. So the question is it because we didn't have, in the 1996, we didn't have the right device? Are we lysing too short? Should we lysis longer? Or do we have just better surgical approaches? So at that time, all acute limb ischemia went for surgery because based on this study. Dr. Topaz did a very nice paper a few years later to kind of challenge that concept, and he compared the recombinant urokinase with vascular surgery in acute occlusion, and was a multi-center trial, 113 patients, and basically comparing vascular surgery, either Fogarty balloon or bypass, with thrombolysis by catheter-directed intraarterial. And infusion was limited to 48 hours, no longer than 48 hours, and we looked at amputation-free survival at 6 months. And you look at it, there was actually no difference between the two approaches, which I think is very important, and that's what changed the way we start approaching those patients. Remember, surgery in an acute leg, those are very sick patients, is not risk-free. You can get complication. But what the keynote was that lysis is more successful if the patient has symptoms less than 2 weeks old. That's what we learned from a lot of studies, that 2 weeks is the cutoff, the golden time, where less than that, usually the clot is more of acute phase, more than that is chronic, and where the lysis does not work. So this is a case example. Again, I reviewed the case. Please don't question me about the case. Be nice to me. So 46-year-old female, history of hypertension, morbid obesity, gastric bypass. She actually had an angiogram that showed a focal plaque rupture with a thrombotic appearing lesion in the left SFA. She had a Viabon stent, symptom resolved. 2 months later, she comes back with the leg pain with an ABI of 0.54. So it is not acute leg ischemia or ALI, but it's acute occlusion of that, or subacute occlusion of the Viabon. So I think it's very important to understand the difference when you have a stent occlusion comparing a covered stent versus non-covered stent. When covered stent close, especially this acute, it's usually thrombotic occlusion. And as Dr. Varkes said, the wire cross easily. That's a bad sign. Whenever the wire cross easily, my fellow is always excited about that. I'm not. That means there's trouble in the horizon. So what do you do in this situation? Would you do a CT, angio, and what's the next steps? We usually CTA every patient to figure out what's going on. And we also do an ultrasound. And you see in the ultrasound, there's an occluded SFA with a monophasic wave. A patient went for angiogram. And when you see with the angiogram, I'm not sure if this is playing. Can you see if that can play, please? No. Okay. So you can see this acute occlusion, but what I want to point out to the middle segment, how you see the contrast is just slowly hanging in there. That is a sign of a thrombus after that lesion. So usually the rule of thumb is you try to avoid balloon angioplasty in this situation. So they crossed this lesion, they put a filter. Unfortunately, they went ahead and ballooned. So the balloon angioplasty tried to put a second Viabon stent, and what happened if they had no flow? And you can see this kind of stagnation of flow, but basically the clot has showered distal, and the patient ended up with worsening pain. Here's one things I always tell our fellows, that when a complication happens, it's just a series of complications. It's just a nidus for more complication. Unfortunately, this patient started having severe pain, then become tachycardic, tachypnic, hypoxic, hypotensive, you name it. They got to start having ST elevation across the EKG. That's a nightmare, right? So the question is what happens? So they get a stat echo, and what they thought is Takotsubo of what ended up happening is like a Takotsubo form of cardiomyopathy. The patient was supported, patient was intubated, and ACT was okay. So they end up switching from just a balloon and stent to they infused 4 milligram of TPA, and then they performed thrombectomy, mechanical thrombectomy with the Bolt 7. And finally, they removed the filter. And you can see now that the thrombectomy has to be covered all the way down to below the knee vessel. So this is your final result. You get good flow, 2 vessel runoff. I think it's a pretty good save. So this patient, again, I think we just talked about it briefly. You watch this patient very closely, make sure you don't have any compartment syndrome, get admitted, check the lactate and CPK, and make sure also the cardiac situation is resolved, because this is was more of stress cardiomyopathy. This is the ultrasound after 2 weeks, and you see wide open vessel. All right, any question?
I'm sorry, they attempted first thrombectomy, is that right?
The first time, they tried to just put another stent.
Okay, I think that this is a perfect case for Lysis first, because the less intense the presentation, I think we have opportunity for Lysis. If this was ischemia 2B, then I wanted something with immediate action, mechanical thrombectomy. But if it's 2A, in this case, it's not even 2A, it's probably 1. There is no even numbness, there is nothing. So I think this is a case that we have time, especially the location of the thrombus was very dangerous in the CFA, so you know you're going to get in trouble if you come across it with any type of device. So I think this case would have been perfect case for Lysis. for 12, 18 hours, brings them next day as a cath lab and deal with it, and it's very acute, so I think we'd have taken care of.
No, definitely, and I think what I'm trying to point out is that, we always forget taking a good history. History makes a huge difference. And even sometimes with a self-expanding stent that's not covered stent, if the patient said, I'm walking fine until 2 weeks ago, and now I can't walk, that's an acute occlusion. But with Viabond, this is more likely than not is a thrombus. So the one thing you're not supposed to do is just a balloon. Go ahead, sir. Yes. I think the filter will be useful if you are planning to do a thrombectomy. Try to protect the distal flow if you're aiming for a thrombectomy. I think Dr. Hammad, what he said, I would approach it this way: either I put a distal filter and do a mechanical thrombectomy, whatever device you want to choose. This way I have it symbolized. Correct. Yeah, and I think you're right, because to put a filter in, that means you're crossing the lesion multiple times. And the more you cross the lesion, the more frequent you cross the lesion, the more trouble you get. I think Dr. Hammad comment is well taken. The way I said the other way I would have approached this is wire, McNamara or ecos, and get out. No pictures, no crossing, no seeing distal, because I have the distal flow from the profunda, and then come back 12, 18 hours later, and you can figure out what's going on. And more likely than not, what end up happening, you have all that dissolved, and either you put usually Viabond stent fail from a distal edge dissection. Dr. Banerjee, you have any comment?
No, I agree. I think in this particular case, it would be meaningful to lyse first, because you have distal flow in the profunda. So instrumentation acutely might not be as meaningful, and the next day it could be a completely different ballgame. So I don't know. I think we should invite all the panelists to chime in, but I agree that thrombolysis is a great idea.
I was just going to ask, do you believe in using an ECOS here for added benefit, or would you just put a McNamara catheter in? What would you guys do?
Does anybody use the ECOS these days? I mean, I agree that lysis would be an ideal thing here, mostly to open up the outflow so you can figure out why the stent went down. The Viabond doesn't go down because of restenosis, it goes down because of poor outflow. So in order to figure that out, I think you do have to lyse it. The question is, like, how do you want to lyse it? And you like the ECOS.
We do usually. Go ahead.
So I want to say I always use ECOS, but I'll be careful just putting the wire and directly putting the ECOS. Actually, we published a very small paper doing primary angioplasty and then lysis versus lysis and then do angioplasty. Actually, just very few patients only, but we always have good outcomes when we did a small balloon angioplasty and established some flow and then put ECOS in. Because it's important, the best lysis for the body is flow. So always try to have some amount of flow before putting the ECOS in, because I have seen even small amount of thrombus, just put ECOS, there's nothing to flow.
So would you do like thrombectomy instead, as opposed to angioplasty? Because then you can, with angioplasty, you can send it downstream. Whereas if you do like small thrombectomy, like, that was the whole idea of the angiojet, right? You like lyse it, make a channel, and then leave a lysis catheter.
Absolutely, but the paper we published was before the time of all the thrombectomy device. So now I just do simple thrombectomy. I don't try to do 10 passes. If I have a decent flow, I just put the ECOS device and get out.
I think the patient presentation should dictate what you do. I think in this case, she had very mild symptoms. At most, she's a stage 1 acute limb, at most, if not even. Then I would not, honestly, I would not balloon. I would not, she has good flow, she has no symptom. I would do lysis. Second day check. I would protect the profundus filter if there's still residual clot in the CFA. If there's no clot in the CFA and they want to fix the SFA, because we need to figure out the underlying issue, why she thrombosed. There's something wrong with that stent. I would make sure I put the sheath all the way, not in the CFA, but in the SFA, because every time you have equipment come in and out of the sheath, you run the risk of that embolize profunda, so make sure that sheath is deep into the SFA when you deal with that stent.
Yeah, Dr. Ramanan, what do you think? When we see,
Yeah.
we do surveillance, we find like bypass grafts that are occluded for who knows how long versus people who come in with like a new symptom. What are the thoughts there?
Yeah, so generally, first for this case, I agree with Lysis. I do the sheath a little bit differently from what you described. I actually purposely leave it in the common femoral rather than put it in the SFA. We've had some experiences where the sheath, like it's occlusive if it's in the SFA. So then we end up pulling it back into the common femoral. So my tendency is to leave the sheath in the common femoral and put the Lysis catheter with basically the holes of the Lysis catheter in the thrombus. So that it directly infuses TPA in
Yeah,
the
I'm
thrombus.
sorry, I agree with you. I'm sorry. I meant the sheath next day when you come. If there's no clot in the SFA and you want to just deal with the SFA problems, then the sheath deep in the SFA. But absolutely, you're right.
Yeah.
If it's for just Lysis, then absolutely has to be above 100%. I'm sorry.
Question over there?
Yeah, I appreciate the. Thanks. Jim Black, Johns Hopkins. I appreciate the points that have been made about acute limb ischemia, and as surgeons, I'm a surgeon, I really feel like you have to be very aggressive about these procedures. This case, obviously, I agree. A viable limb, class 1, no great rush. But one thing that everyone should keep in mind is the reason that this lady thrombosed is probably most likely just good old-fashioned obesity and hypercoagulation. So this is someone that probably the most important thing we can offer her is long-term anticoagulation, hypercoagulation workup. Most people, at least in my experience, this age group, 40-year-old, even diabetics, they just shut down stent grafts just because they want to shut down stent grafts. They don't have to have an edge lesion, they don't have to have an edge dissection. Just being fat and 40 and female, these are the risk factors we talk about in surgery all the time. So yeah, you've got to keep that in mind.
Definitely. I think knowing why this graft failed is important. And the question is, 40-year-old, should they have a PAD in the first place? Right, if she's not diabetic. The question, I would love to see the first case, and figure out why this patient had a Viabon in the first place as a first-line therapy on a 42-year-old. But again, that's not the point of that. Any other questions? All right, so you guys get double dose of Sayfo today. So I'm on next one. Can I have the next slide, please? So this is my talk. Now I know this one better than the first one. Sorry for that. All right, so I was told to give a talk for thrombosed bypass graft at the presence of 2 surgeons in the panel. That's not fair. One of you guys should have presented that, but I'll try my best. So when you look at femba bypass occlusion, there's really not a lot of papers that I was able to find, but usually they say the cause will be either technical issues, intimal hyperplasia, or progression of atherosclerotic disease. And of course, that depends on the type of the bypass graft that was used, and I will assume in this incidence is the vein graft that was used. And the type, it can be acute, intermediate, or late graft failure. And a treatment option that was proposed is surgical revision, balloon angioplasty and stenting, catheter-directed TPA, mechanical thrombectomy, or repeat surgery. So this is a case of a 74, I have 3 cases. 74-year-old male, this is not a MIC, that's a male, with a history of a left fempa bypass 10 years ago. And after a failed left SFA stent, he came with acute onset of a leg pain of the left side within 24 hours. Has all the risk factors, CAD, diabetes, and smoker. He's on aspirin and atorvastatin, and not on anticoagulation. There was no recent trauma or knee surgery or anything that possibly can be a traumatic cause of this. So it's important to go back to medical school, the 5 Ps to recognize acute limb ischemia. And in this case, it's the acute onset of the pain within 24 hours, the pulselessness, the pallor, the presthesia, and the paralysis. This is a nice paper that was published at the Annual Vascular Disease journal. And it's very important for us to recognize this. I think people mix Rutherford classification versus acute limb ischemia. And I think it's important for our fellows and residents to understand the difference. And I think it's important to know what's viable versus threatened A, which is 2A, 2B, or 3, and how can you recognize it. And when you go to examine a patient, you need to recognize which one this patient has, because the treatment is completely different. So that depends on the sensory loss, the muscle weakness, and of course the Doppler signals. And here's the algorithm. It's the same paper. And basically what's important here, if you have a classification 1, you have time to take that patient for a CT, for imaging, for a lot of, you have the luxury of doing so. If you have 2A, you can still have it, but again, you don't sit on it, you try to expedite it. 2B, usually patient need revascularization sooner than later. And the most important one is 3. This patient, their recommendation is amputation. The more you do, the more you harm the patient. If the patient has a classification 3 and you try to go to open that vessel, you're only going to harm the patient. So you go from acute limb to a dead patient. Those are different devices. I mean, that's not all the devices available, but this is some of the devices available for acute limb ischemia. Ecosonic fragmentation, including McNamara's and TPA's. Thrombectomy, Bolt 7. Inari now, I don't think has been used much anymore. Imperative care has something called Prodigy, and then you have the Bounce from Surmotic. And of course, the Jedi, I forgot to put that one here. This is the angiogram. So this patient getting an angiogram, you can see the old stent in the SFA, you can see the nub of the graft, and this patient received a Bolt 7 penumbra thrombectomy, and that's the distal vessel. So again, I don't see a distal dissection, I don't see a proximal issue, so the question is why this patient had that failed, and this patient ended up getting a hematology consultation for a full workup. So what's interesting about using the Bolt 7 is that most of us, when we use it, we actually use it, we cross with a wire and we take the wire out, and we do it without a wire. We do it without a filter. My experience with it has been, it depends on the patient, of course. If I have a Viabond that's failed, it's a different story. When I have a graft or an acute leg, like an embolic event, I don't put a filter in those cases. The suction is so good, I don't even put a wire. But again, this is a graft. There's no atherosclerotic disease. Case 2 is 62-year-old male, history of PAD, had a femba bypass, and he had a 2 weeks history of worsening pain. Again, different kind of story, different flavor. This patient is on aspirin and Eliquis. His leg was warm, had diminished pulses. An angiogram, you can see an occlusion of that bypass, but there's quite of a collateral. So this patient did not have a true acute leg. So this patient graft has been failing slowly over the years. In this case, we used a Bounce thrombectomy device. And you can see the collagenous kind of shape. This is a basket base instead of an aspiration based. And you can see the distal part of where the distal anastomosis had a problem, had a dissection that was treated with a stent. This is the newest device. This 65-year-old patient, female with a history of fempa bypass, came with acute legs, again, CT occluded graft, same old story. And the interesting part with this arterial one, I think if the people in the audience who do venous work, or PE work, you used to get way more clot from the venous and the PE. When you come to the arterial, you do all this drama, middle of the night, they're calling you at 2 a.m., everybody driving, and they come in and the clot you get is like this small, tiny piece. It's not really, you're saving the patient leg, but you're hoping for a better clot, for a better picture, but sometimes it's as small as what we just saw you. So the clinical challenge, and I want to ask the audience, the physician, the panelist, is what approach should you use? When do you use echos? When would you use thrombectomy? When would you use surgery? And when would you use a surgery plus thrombectomy? How fast should we proceed with the intervention? Does multidisciplinary approach really needed? And I think we touched on that already. And when should we consider fasciotomy? This is a paper called the STRIDE study. It's an international multicenter study that was done treating patients with using Bolt 7. And if you notice, graft was around 16% of those patients, and primary input was a limb salvage achieving 98.2%. That's pretty impressive outcome. Dr. Charles Bailey had a nice paper recently that's showing his own experience, I think 60 patients or so, and it was an impressive, he predominantly use an endovascular approach, and what his approach sometimes what he does, he said, I go in, I open the profunda, I stabilize the patient, and I can take the patient to surgery later on. So this is a question I want to ask the panel as well. So occluded graft does not mean it's acutely occluded. I think we just need to recognize that because it can be occluded for a long, long time. Protect the distal vessel is extremely important. I believe multidisciplinary approach is absolutely important. Doesn't matter if you're an interventional radiologist, vascular surgery, or cardiologist. This is not just one department disease, and endovascular approach is a valid approach. Thank you.
I wonder, when we do these cases for occluded bypass, we, you open them and it looks good angiographically. Do you IVUS them routinely? Because sometimes you look, and I've always been surprised at how much worse it looks with IVUS, and then if it's worthwhile to go after that. Just asking the panel, and you, Dr. Sayfo.
I'll
Yeah.
let the panel answer.
I do always do the IVUS and see where the pathology is. But when you do the IVUS, it's so different angiographically, you will still see the thrombus. But I rely on the flow to decide we should do more thrombectomy or echos.
From the coronary perspective, we IVUS the vein grafts not infrequently if we're stenting, and it's impressive the amount of positive remodeling and just atherosclerosis and partial thrombosis that's on the inside of those vessels. So that's why in a coronary space, we know undersizing stents slightly in vein grafts is actually more beneficial because of that process that's going on there. If it's so I guess to answer your question, yes, I would. Even especially if it's a venous graft, because then if you do have new atherosclerosis, depending on the age of it, you can choose whether you're going to spot stent or if you're going to just balloon and leave things alone.
Yeah, so for like the first case, the PTFE bypass graft that went down after 10 years, which is pretty good for a PTFE bypass, right? Usually I tell my patients 2 years, right? So, 10 years, but like, how was the distal anastomosis there? Did you look with the angio? Did you IVUS it? Like, how did you know that?
So I'm at fault of not IVUSing as much as other operators. So I don't IVUS unless I cannot explain the problem. So in that patient, I should have IVUS because I don't have an explanation why the patient graft failed. And I think it's important to IVUS because sometimes angiographically we're failing to find the problem. And maybe there's distal anastomosis problem or proximal anastomosis problem, but I did not, unfortunately.
You guys down here, I thoughts on IVUS?
I'm sorry. I do IVUS if I cannot figure it out, but actually I had a question. The distal anastomosis looked a little bit aneurysmal. I'm not sure if that would explain. I know you had a good flow, but you were injecting almost very close to. I wonder if you inject from the top, if the flow would be swirl, and that would be, a reason. Maybe I don't know if it would explain everything, but it looked aneurysmal, the distal anastomosis. And the second question: when you decide to go after native, versus you trying to open up the bypass?
Say it again. So what's the question?
When you decide to go after native rather than trying to open up the bypass?
Well, that's a great question. If you ask me next door in the coronary session, I will answer that question, but that's a good question. I think in an acute setting, I would still open the graft. It's easier to cross. It's, we have now devices that can acutely in the middle of the night allow me to open it really quickly, because try to open an SFA that has been included for more than 10 years and they have sutures, I think it's very difficult. It's doable, but usually when I do that, I usually go pedal in those cases. I get more success with pedal, but I would not do it in acutely. Coronary is a different story.
Actually, it's interesting, in this patient had bypass surgery because of failed stents. So now you're going back and opening an CTO. I don't think the long-term outcome would be good.
Yeah, I think the times I've gone to recanalize the native system for a failed bypass, it's because the vein bypass went down. And so if the vein bypass goes down, that's probably their best option. After that, all bets are off, whether you're going to do a redo bypass with PTFE versus recanalize the native system, unless the native system has failed endovascular attempt before. Dr. Ramanan, thoughts about that?
I think also that this is a PTFE bypass that's 10 years old. It is going to fail again because it's reached the end of its life. So we have to think of some other options, either a redo bypass or something else. Even though it's been opened right now, it's going to fail again.
Again, I think this is where you always keep your vascular surgeon close to your heart because you're best friends. And when I get a question like this, it's not about being a cowboy, even though I'm from Texas, but it's about doing the right thing for the patient. So if redo surgery on more stable situation is the right answer, then that's what you have your good friends in vascular surgery. Definitely agree with that. Yes, sir.
So my question is to Dr. Tsai. How often, I'm very concerned with using mechanical thrombectomy in a prosthetic graft, which has a very large volume of thrombus in it. A tiny bit of thrombus can go down into and block the trifurcation of the pop. and the patient is going to have acute limb ischemia, because there is no thrombolytic on board to dissolve the distal embolism. Have you seen that? Do we have that data?
Oh, I have definitely trashed the outflow. So, I mean, I think we've all done that. And so, in patients who have chronically occluded bypasses and are not symptomatic, I leave them alone. Like, I always tell them that if we find your stent or bypass to be occluded by accident, I'm not going to go after it at the time, because there's a high risk of trashing the outflow in that case. But if they're acutely ischemic and this is an acute thrombotic event, then I think you have limited options. I would ask the panel what else they think about this, because there's definitely the risk of trashing the outflow whenever you do this, whether you use even if with a filter, because I've done it with the filter and like clotted the filter.
The problem with the filter, that those clot, so first of all, majority of this clot, yes, the graft looks it's all occluded, but in reality it's not. It's just the distant anastomosis has a clot, you take it out and the graft open up very nicely. Not all the time, but a lot of time. Putting a filter, what would happen is, if you look, for example, just as a device, Bolt 7 is a curved device. Sometimes has double curve on it. So you want to be able to rotate freely. That's why we usually use it without a wire. That means without a filter. So it's risk and benefit, I think, how old the graft, what type of graft you're dealing with. Is this acute leg within the last 12 hours, or this is something going on for 2-3 weeks? I think that make the approach different. But if I have someone coming with true acute limb ischemia from a graft occlusion, I just go with thrombectomy. I don't put a filter, and usually what it is, it's just a small clot that distal anastomosis. You see a dissection or an injury there. You put a stent there, and the whole graft is wide open. But again, this depends on the age of the occlusion. Any other panel?
Well, I was going to say, my experience with these new thrombectomy devices is that the suction on them is so good that I don't worry quite as much about having that distal protection, especially in the acute limb. And we're talking about acute limb, so as far as getting to the mechanism of what the failure is, I mean, live to fight another day. If it means dropping a lytic catheter down and getting the patient out of a trouble window, you can then spend more time as well to figure out what the right thing to do in the long run is. But I agree that putting a filter down in some of these acute limb settings, especially with the new devices, is not as necessary.
Perfect.
One last comment.
I think this is a great point. Honestly, for this reason, that's why I asked the question. Myself, I have extremely low threshold to go after the native, depending how old the bypass and how acute and the age of the presentation. But I have a very extremely low threshold to go after the native. For that reason you mentioned specifically.
No, I think that's a good point. Any last comment before the next speaker?
I would like to know what percentage of people use filter devices when treating acute limb ischemia.
You do, you do not.
I don't. I would like to know in the audience or panel.
Raise your hand if you do acute limb without a filter.
I was asking with, but without filter.
So everybody else is with. So who does it with filter? Every single case.
Yes, it depends.
All right, so we'll move on for the next case. Dr. Bashir is going to be talking to us about balloon pulmonary angioplasty and CTEPH.
Good afternoon, everyone. Dr. Banerjee, thank you very much for the kind invitation. I'm going to switch from lower extremities to pulmonary vascular bed. And since this is a Cardiovascular Innovations Summit, there is a lot of room for innovation in vascular bed. And hopefully we'll highlight some of those today. I'm going to present a case of balloon pulmonary angioplasty for the treatment of chronic thromboembolic pulmonary disease. Not necessarily pulmonary hypertension, but pulmonary disease. It's a 56-year-old gentleman, very active, plays soccer, tennis, hikes all the time. 6 months ago, during his travels, he developed an acute intermediate risk pulmonary embolism. I was treated with a NOAC. He recovered very well within a month or so. And when he started playing again his sports, he noticed that he wasn't feeling as well as he did before. And he also had some mild chest pain and felt a little dizzy. So his cardiologist ordered an echo and a stress test. Both of them were normal. His PA pressures were normal, his RV size and function was normal, as you can see on the echo there. So he sent him to a pulmonologist, and the pulmonologist did a VQ scan. And the VQ scan, as you can see, shows multiple segmental bilateral perfusion defects. This is a classic VQ scan of a patient with pulmonary vascular obstruction. So he did a CT scan, and CT scan confirmed severe segmental artery stenosis of his pulmonary arteries on both sides. And you can also see a very large bronchial artery collateral coming off the descending thoracic aorta going to the right pulmonary trunk. So his 6-minute walk distance was 530 meters, which was consistent with an NYHA class 1 symptoms. His mean PA pressure was 23, and his PVR was 3.7. So the clinical challenge here is, how do we know whether this pulmonary vascular obstruction is causing his dyspnea or not? And the best way to answer that question is to do a cardiopulmonary exercise testing. And we at Temple do an invasive CPET in the cath lab using a supine bike and a metabolic cart. And the advantage of this is it gives us both resting and exercise hemodynamics, and it also gives us gas exchange variables like VVCO2 and end-tidal CO2. So here are the exercise hemodynamics of this patient. His mean PA pressure increased from 22 to 57. But his cardiac output and his cardiac index augmented very well. However, his pulmonary vascular resistance did not drop. So your pulmonary vascular resistance should drop with exercise. So his heart was working fine, but he wasn't able to, but he was still generating a significant pulmonary pressure. And that was because of gas exchange problems. His VVCO2, which is a measure of dead space ventilation, was significantly high. So normally it's less than 30, and in his case it was 40. And at peak exercise, he dropped his oxygen saturations to 85, and his mixed venous oxygen saturations dropped to 16% from 67. So this was all consistent that his dyspnea was related to pulmonary vascular obstruction based on this CPET test. So based on these findings, we did a pulmonary angiogram on him, and you can see how tight severe segmental artery stenosis he has. This is his right pulmonary artery in AP and lateral view, and this is his left pulmonary artery in AP and lateral view. Now, how do we decide treatment modality for these patients? And that primarily depends on the location of the thrombofibrotic lesions in these patients. So if the lesions are in the proximal artery, like interlobar artery, or in the proximal segmental arteries, thromboendarterectomy surgery is the best treatment. It's potentially curative for these patients. However, if the lesions are more distal in the segmental arteries, balloon pulmonary angioplasty is a very reasonable option. And if patients have microvasculopathy, they undergo pH-targeted medical therapy. The most important thing is that this decision cannot be made by one person. It has to be made by a multidisciplinary team. And that multidisciplinary team has to include an expert CTEPH surgeon, because CTEPH surgery is curative in these patients. And if you're not having the best surgeon look at that angiogram or that CT scan, you may be suboptimally treating that patient. But because this patient had mild symptoms and his hemodynamics were not that bad and he had very good targets for balloon pulmonary angioplasty, the team decided to do a balloon pulmonary angioplasty on him. Now, how do we do balloon pulmonary angioplasty? We usually use a femoral access, take a long 70 centimeter 7 French sheath. We use a 6 French guiding catheter through that sheath. usually a multi-purpose and a JR4 for the right side and an AL1 for the left side. Guide liners are very helpful. We usually cross the lesion with a BMW or a radii wire. I use a 300 centimeter radii wire, sometimes a run-through wire. Most of these lesions need a balloon support to cross. They are very tight, even though they may not look angiographically very tight. And then we perform a balloon angioplasty over the wire. The reason I like pressure wire in these patients is, as you can see, proximal to the lesion, the waveform is normal. The moment you cross the lesion, the waveform turns like a wedge tracing. And when you pull the transducer of the wire back into the lesion, it ventricularizes. So it exactly identifies where your lesion is and where you have to dilate that vessel. And your goal of dilating this vessel is to restore pulsatile flow. But don't normalize the pressure to the proximal pressure. You just want to leave the distal pressure less than 35 millimeters of mercury mean, because otherwise the risk of reperfusion pulmonary edema is significantly high. And that's what we did in this patient. So we did 4 sessions, 17 vessels, 33 lesions, and we did multiple kissing inflations because of bifurcation lesions. And after that, his mean PA pressure was 12, and his PVR was 2. So his 6-minute walk distance increased by 55 meters. His dead space ventilation completely normalized, and his peak oxygen saturation normalized as well. And his quality of life improved with every single session of balloon pulmonary angioplasty. It's one of the most gratifying procedures that you can do in interventional cardiology, is to treat these patients. They dramatically change their life. And here are a couple of examples of our cases. This is a lobar artery occlusion, and you can see the reperfusion. And here is the perfusion post-balloon pulmonary angioplasty before and after. And we reported our initial experience of 211 sessions in JAC last year. And you can see that there was a significant reduction in pulmonary vascular resistance, a 70-meter increase in 6-minute walk distance, a significant decrease in BNP, and improvement in pulmonary artery compliance. Now, why is everybody not doing it? And that's because of complications that are associated with this procedure. The biggest one being hemoptysis on the table. 5 to 10% of these patients will develop hemoptysis on the table. So you have to be ready to treat hemoptysis on the table. So that's what is the Achilles heel of this procedure. And a small percent of patients can develop reperfusion pulmonary edema. So in conclusion, in a patient like that one I presented, cardiopulmonary exercise testing is critical in understanding whether the symptoms are related to pulmonary vascular obstruction. And if a patient does have pulmonary vascular obstruction causing symptoms, surgery is first-line therapy, and it is curative in these patients. But in patients who are inoperable or are high surgical risk, balloon pulmonary angioplasty is an excellent option. And I finally want to acknowledge my CTEPH team at Temple, and thank you very much for your attention. I'm happy to answer any questions.
Thank you for the presentation. I mean, this is a very, very interesting topic, and we have one of the world experts in the room, so we're going to ask you a lot of questions. Take advantage of your expertise. So you mentioned something very important, having a CTEPH surgeon. So do you recommend people not to do this in centers that do not have a true multidisciplinary approach and just refer the patient to the right centers?
Yes, I do. I think it is really critical that these patients be seen by an expert CTEPH surgeon and an expert PH specialist. The subtlety of this disease is such, because dyspnea is caused by hundreds of things. And if you are picking up a wrong patient and that patient has hemoptysis on the table and potentially can be fatal, there is no legs to stand on. And because of this cardiopulmonary exercise testing is also very challenging to interpret. So you need real experts to do that. And in absence of that, I think it is an important thing that we have expert surgeons, because there are a lot of surgeons who say they do it, but really they haven't done enough distal dissections and the thromboendarterectomies.
I believe it's not just the surgery. I think it's also having the right setup. It's like an LVAD. It's not just the surgeon doing the surgery. It's the post-care, it's the ICU, the nurse taking care of the patient. Dr. Banerjee, you have a question?
Sure. Mhm. Correct. Thank you. Thank you, Subhash. All these three questions are really critical. And to answer these questions, we need to understand what we are doing by ballooning a lesion. That the definitive treatment is surgery. When a surgeon comes out of the OR, he has every single vessel opened. The patient starts with a pressure of 100. In the recovery, his pressure is 20. All the vessels are clean. We're not doing that. We're working in one lobe in one session, and the patient's pressure is still high. So what we are doing is we are picking up low-hanging fruits to get the pressure down. So if you have 50 lesions in both lungs, and 20 of them are low risk, so we would treat the 20, get the pressure down, then we can go to high-risk lesions. So that's how we are thinking of how to approach the lesions. Now, in terms of what is the gradient, the gradient issue is Matsubara from Japan is the one who pioneered this technique. So what he did is, we started this in Brigham first in 2000, and there was 61% reperfusion pulmonary edema because they were using nominal sized balloons. And what Matsubara found was that if we use small sized balloons first, get the pressures down, and then use optimal sized balloons in future sessions. And that is what made this balloon angioplasty safe. So that's what's called refined balloon pulmonary angioplasty, is we use smaller balloons first, get the gradient better, and by that the pressure drops, and then we can use optimal balloons. So that's why pressure wire has made it safer for us. Because when I'm doing it for the first time, I don't want the distal pressure to be more than 35 millimeters of mercury. Usually we do lower lobes first, right lower lobe, left lower lobe, because the gas exchange is maximum in those areas. Now, the challenge with VQ scan is these pulmonary arteries are like a trunk of a tree, and there are 6 branches coming at one spot. And at the apex of that trunk, it's an occluded vessel. And I'm going into one branch, and I'm going into the second branch and giving high five to my fellows that we opened up this vessel. But there are 4 other branches that I never saw because they were osteally occluded. So it's difficult in that sense. So, and it's an evolving field, and we need to answer all these questions scientifically. You know, whether we're making a difference by doing this pressure wire in terms of safety.
So if we have 2 more questions, then we're going to move to the next speaker.
So you made the point, really interesting, not something I do either, but I do a lot of PE as far as thrombectomy and lytics goes. And our pulmonary group and our CTEPH group is starting to talk about this. You demonstrated that you use long wires and oftentimes workhorse coronary wires. Your pressure wire is a short wire. So how are you, the feasibility of that, are you buddy wiring next to it? Are you working over your pressure wire? How are you doing that? And then
So I don't use a short pressure wire. I use a 300 centimeter radii wire. And the reason is because it has a, you know, the software on the back end, torquing becomes difficult. But if you have a 300 centimeter long wire, you can torque it easily. And it's all on the balloon. The balloon goes on the wire from the beginning. But many times your guide position is not stable because patient is breathing as you are doing this procedure. So many times I have to use 2 wires. I would have a short BMW in one vessel to stabilize it, and then take the pressure wire in the branch and measure the gradient, or get the BMW into the branch of interest and then buddy wire it with the radii wire. And there are cases that are lesions where the radii wire will not go through, or it's too dinged that I would just continue to work on the beamer.
what's the rate of restenosis in these? Because these are fibrotic lesions.
Actually, that depends on the type of anatomy you are dealing with. Most of the distal lesions actually get better with time. So instead of restenosing, they actually remodel, and the vessel looks better the next time you see them. But in patients who have surgical disease, and they're not surgical candidates, and we're doing very proximal, highly fibrotic lesions, there is a significant amount of recoil in those patients. And those patients might need some sort of scaffolding, preferably a bioabsorbable scaffolding down the road. But at this time, only thing we have is a stent.
Do you put the patient on antiplatelets or anticoagulants?
They're all on anticoagulation, no antiplatelets.
All on anticoagulation. So you stop it, you do the procedure, and when do you resume them?
Correct. So we would stop, if they are on a NOAC, we'll stop 24 hours before and do the procedure and then get them back on the NOAC the same day. If they are on warfarin, we'll give them Lovenox for 3 days, then do the procedure and back on Lovenox and warfarin.
Well, thank you so much. It was very informative. Appreciate it. And
My pleasure.
thank you so much for the presentation. We keep the best to last. Dr. Ramanan talking about surgical embolectomy and when should we do it, and the stage is yours. Can we move to the next talk, please?
Thank you for the opportunity to talk here. So I'm going to be presenting 3 cases, and I'd like your opinion about how people would approach this. So first one is a 70-year-old male with 1-week history of foot pain and dusky toes and inability to move the toes well. He has had previous interventions, so dry gangrene and toe amputations 1 year prior, and some other unknown leg interventions. He's also had a stroke with severe aphasia and a right arm contracture. So he had Rutherford probably 2B ischemia. So this is his CT. So you can see his left side external iliac is occluded, and the right SFA has a flush occlusion. There's a reconstitution of the above knee popliteal artery, and then it re-occludes below the knee. The runoff was unclear. So these were what we thought were our options. Endovascular approach, should we do lysis in this patient who's had a recent stroke, or just do thrombectomy? And then if we do endovascular, what would be our axis? And then open surgery, what would be the approach, and should we do a fasciotomy? So we decided to do an open thrombectomy, primarily for a couple of reasons. One, we thought lysis would not be a good option in him, given his stroke. He also didn't have good access because his external iliac was occluded on the other side, and we didn't want to put a lysis catheter through the arm. So we decided to do a 4-compartment fasciotomy and an open thrombectomy. So we got some return of fresh thrombus, and we did a popliteal incision so we could actually thrombectomize the tibials. So key learnings in this case for us was the choice of therapy is dependent on multiple factors, including overall patient health, ability to tolerate lysis, availability of arterial access, and severity of the ischemia. Prophylactic fasciotomy was mainly performed due to the severity of ischemia at the time of presentation, and the location of incision for an embolectomy depends on the site of the thrombus. So this is a second case. This patient is a 60-year-old who presented with pain in her left AKA stump for 2 to 3 weeks. She had previously, 3 weeks prior, had an Impella-guided PCI of multiple vessels, and she had had an axillary Impella for this. She had left ventricular thrombus and then all the other vascular procedures that were listed. So on exam, her left AKA stump was cool and mottled, and it was pretty painful to touch. And on exam, she also had a large axillary hematoma from her Impella, and she had no radial pulse on the other side. This is her CT scan. So she had had previous iliac stents. The right-sided stent was known to be occluded, and the left side stent was now occluded. And she has a left AKA. So what should we do for her? Should we just do a primary higher AKA or a hip disarticulation, or do some kind of a procedure to open up her inflow to that left AKA? And then that would be either endovascular or open surgery. So we did a hybrid approach. We exposed the left common femoral. We did an over-the-wire Fogarty embolectomy, but we really didn't get much clot out. And then we basically stented her all the way from the aorta into the groin. So maybe in this patient, looking back, maybe a total endovascular approach would have been preferable. Given the lack of acute thrombus, we thought, based on the patient's history, that it was more acute, but perhaps this stent had been occluded for a longer time. And given her medical comorbidities, maybe the better approach would have been to go with a higher AKA or a hip disarticulation, because unlikely that these stents are going to stay open for a very long time. My third case is a patient who presented with a fall and inability to move the legs. He was 50 years old, had the usual cardiovascular comorbidities, but he had hepatocellular cancer, and he had had a recent RFA ablation for a liver tumor, and his anticoagulation was held for that and then not restarted. So when he came in, the patient was paraplegic, and bilateral legs were cold up to the groins and pale. He had no pulses or signals in the legs. And this is his CT scan, which shows an aortic occlusion. Both his common iliacs are occluded. There's reconstitution of the external iliacs and the hypogastrics. And that's the 3D view of the CT scan. So given his overall comorbidities, we considered different approaches, endovascular, total endovascular versus open surgery. And then open surgery options we considered were whether he was a candidate for an aortic bypass or an extra-anatomic bypass like axillobifemoral bypass, and then whether he needed a fasciotomy. So we actually, again, did a hybrid approach. We cut down on his femorals in order to protect the legs from getting embolism, and we actually did a Fogarty balloon thrombectomy of the aorta. Ultimately did stent his iliacs, and then we did 4-compartment fasciotomy. However, this patient continued to be paraplegic. He ultimately developed colon ischemia and then had a colectomy and an ankylostommy, and then was discharged to rehab. Key learnings from this case was acute aortic occlusion is associated with a very high morbidity and mortality, and colon ischemia is usually due to embolism. It has a high rate of major amputation, and colon and spinal cord ischemia are associated with a very high mortality. Thank you.
Who want to start? Those are three very sir, you're a vascular surgeon, correct? Yes, sir. Okay. I can give you mine.
Thank you, Dr. Urbana, for your presentations. I'll start with the first case, which is acute ischemia. And now we are not opening over the below knee popliteal because we need to patch it. What I do, I open all the cases as a femoral, and there is over-the-wire Fogarty. So you can pass the Fogarty and do an angiogram, and then if you are open the anterior tibial, for example, you can pass the wire to the posterior tibial and peroneal, and then you clean them by Fogarty through the femoral. The last case, which is aortic occlusion, did you explore the patient through laparotomy or just femoral?
Yeah, we didn't explore him through a laparotomy. We thought he was sick. He had hepatocellular cancer, and we thought that if we did a laparotomy, he may not survive an open aortic operation. And that's why we decided to do it through the groin.
Yeah, because I have the similar case a few weeks ago, and he's a high-risk patient. But if he comes with a paralysis, you will never be able to save his limbs unless you do aortic exposure. And you can do a limited exposure with endarterectomy for the aorta, and then you do retrograde thrombectomy for both iliacs, and the patient was saved. Thank you.
Yeah, we were not sure what the cause of the spinal cord ischemia is, and a lot of the time in these aortic occlusions, it's because of embolism to the spinal cord. It could be from direct ischemia from the lumbars getting occluded, but we thought we could open those with the thrombectomy. And actually, the final pictures were pretty good, and his hypogastrics were also open. However, he still continued to have spinal cord ischemia, probably because of embolism, as well as colon ischemia. So.
There was a case done at Kentucky University with an exact same picture in a young paralytic patient, and they did the same from the groin. But what they did is they gave thrombolytic sprays into the abdominal aorta where the thrombus was. They gave 10 milligrams, waited for 30 minutes, then cleaned up everything. That patient walked out of the hospital 7 days later. So this patient seems to have much more larger volume of thrombus because he seems to have infarct of the kidney as well.
Yeah, I agree. Also, I don't know if we would have considered Lysis in him, given that he'd had a recent liver procedure. He had had an RFA ablation of a liver tumor, and so we didn't want to give him Lysis because of that.
We have a question in the back.
I'm Ann Kelly Rudy. I'm a vascular fellow at Baylor, and I was saying that we had a very similar patient presentation last week, a patient with acute aortic occlusion and lower limb ischemia, borderline Rutherford 3, really. We ended up taking him for an open aorta bypass, and unfortunately in the operating room, he ultimately passed from a reperfusion injury. So in these patients, how do you kind of prepare for that? Obviously, with an aortic occlusion, you can't exactly say no to revascularization. How do you communicate with your anesthesia? How do you communicate with ICU to, prep them for that?
Yeah, given the volume of thrombus when there's an aortic occlusion, there's a very high likelihood of reperfusion injury. And what happens is when you reperfuse the legs, they become severely hyperkalemic, and they usually die because of cardiac arrest. We usually give anesthesia a heads up that when we reperfuse, they have to be ready to treat the potassium. Sometimes if it's really bad, we'll have CRRT in the room and start CRRT while the patient's in the OR. It's rare that we have to do that, but that is an option and one solution for the hyperkalemia. I've had one person die of hyperkalemia when we reperfused a leg, not this patient, but another patient, and that's a really well-known complication of aortic occlusion. So,
Yeah.
but we have to have anesthesia ready to deal with hyperkalemia, essentially. And the other thing is sometimes you have to do amputations of the legs because that's the source of the potassium.
Yeah, for these patients with high volume thrombus, we have actually gone to extensive lengths to get dialysis in the OR and started before we reperfuse them because there is such a huge rush of acidosis that comes back when you reperfuse them. Back in the day, they would vent the vein. I've never done this. I don't know if other surgeons have done it, but they would just stick the vein to like let everything sort of exsanguinate out. I think these days, we
Doctor,
tend to-
I mentioned that actually while we were doing the case,
Yes.
well, afterwards actually, and he kind of said that he had mixed, you know.
I'm not
opinions
sure
on it.
how effective that was. I've never done it, but that was sort of the teaching back in the day. But I think now it's like we would, you know, part of getting these patients lined up is to put a dialysis catheter in, not only for the impending renal failure, but also to clear the acidosis when you reperfuse them.
Yeah, we usually put the dialysis catheter before we start the case, like before we do the operation, just to be ready to do dialysis.
I have a comment and two questions. So one comment is, first of all, Dr. Banerjee, thank you so much for putting this topic. This is the first time I see acute limb ischemia in a cardiology conference. So I applaud board of directors for that. Second question is, as vascular surgeons in the room, do you see a shift from surgical approach to endovascular approach as the new thrombectomy device is coming in? There is one question. Second question is, do you anticipate any randomized trial for surgical versus endovascular approach for this particular case?
For aortic occlusions?
ALI, not aortic, acute limb ischemia. Sorry.
Yeah, so yes, there has been definitely a shift from open surgery to endovascular therapy. So this aortic occlusion, there was a case series that was done in Germany. There's also another paper out of Sweden. They have shown like an 8-year experience, and there has been a transition from more open surgeries to more endovascular procedures, even for aortic occlusions, over the last 8 years. And actually the outcomes are better if you try to do more endovascular rather than open. These patients do not tolerate open aortic surgery. Even an aortic endarterectomy, even though it sounds simple, they are very sick to start with, and so they don't really tolerate open aortic surgery very well. And so I think the way to go is endovascular. If we had the option of maybe doing a flash, maybe we would have tried it before doing groin cut downs, but we thought that was kind of the best of both worlds. Where we
I
tried to get
think what you just
clot
mentioned is
out.
very important. I think the size of the vessel can define what endovascular device you use. If you start using you use a bolt 7 in this, that's just not, you're wasting your money. I think either 16 or 12. I think we have a question, Nalis.
One comment about these acute aortic occlusions, they usually have quite large thrombus volume, or it's one of those like saddle picture. So if the groin is actually virgin groin, then my preference is to do cut down to control all the vessels so we can prevent embolizations. But if it's redo or hostile groin or very obese patients, then I tend to go endo first. But I size the sheaths in a way that it's occlusive to the vessel. So as you're operating, you basically have a vessel occlusion through the sheath, so you can't have any distal embolizations. And because the sheath is so large, you can remove most of the thrombus from it. So that's how I approach aortic occlusion, should you do through the femoral approach. Yeah. And in terms of the acute limbs for the legs, I think it also depends on the patient's age and then the underlying disease of the vessels. If the vessels are all clean, it's actually, and it's like, let's say some 40-year-old patients who had embolizations with otherwise normal vessels, then I think it's really quick to do cut down and then do embolectomy, and you can actually get very clean or complete embolectomy. But if a patient has underlying disease, then doing forward thrombectomy is quite challenging because the balloons usually rupture. And for those, I think the preference is to endo first.
It also depends on the age of the thrombus. If it's really acute, then it comes out easily. Whereas if it's subacute or chronic, you're not going to get clean outcomes.
Perfect. Okay, but I think we'll adjourn today. Thank you for everybody. I just want to get a reminder.